Welcome back to the Deep Dive. Our mission, as always, is to take a really complex set of sources today, it's a whole pharmaceutical landscape, and break it down so you can achieve that elite professional level of mastery. And today, wow, we are diving deep into the agents used for pain, inflammation, and those chronic immune diseases. Okay, so let's try and unpack this. It's a huge area. We're looking at everything from, the stuff you grab over the counter, aspirin, acetaminophen, warrant, all the way up to these incredibly specific, really cutting-edge biologic drugs, the DMARDs, Disease-Modifying Antirheumatic Drugs.
Yeah.
We need to get beyond just what they are. We need to understand exactly how they work inside the body, at the molecular level, whether it's for acute pain or something chronic like rheumatoid arthritis or even metabolic stuff like gout.
Absolutely. And understanding that molecular context, that's paramount. Because remember, inflammation itself, it's not inherently bad. Normally, it's a very organized, protective response. It's how the body handles trauma, fights off microbes, deals with chemicals. It's essential for cleaning up and starting repair.
Right, it's supposed to help.
Exactly. The trouble starts, and this is where most of these drugs come in, when that immune system gets activated inappropriately. Like in rheumatoid arthritis, or RA. Our sources really paint a picture here. Your own white blood cells basically lose tolerance, they start attacking your own tissues, specifically the synovium, that lining inside the joints. And it's a destructive attack. You've got T lymphocytes pulling in monocytes and macrophages. These cells then pump out huge amounts of inflammatory signals, cytokines, especially things like TNF-alpha and interleukin-1, IL-1.
And that leads to the joint damage we see.
That's what drives the chronic joint destruction, the pain, the disability in RA. It's the body attacking itself.
So we're not just talking about dulling the pain from a twisted ankle here. We're trying to actually stop a systemic self-inflicted attack, which means we need drugs that do more than just kill pain. We need things that can actually modulate or reduce those inflammatory and immune processes.
Precisely. Halting progression, restoring quality of life. That's the goal.
Okay, so to start this journey into molecular intervention, we have to begin with the main targets for so many common drugs. Prostaglandins. What exactly are they, and why are they so central to pain, fever, inflammation?
Right. Prostaglandins are part of a larger family called eicosanoids. Chemically, they're unsaturated fatty acids. They have 20 carbons, a distinctive cyclic ring structure. Their big influence comes from being local mediators. That's key. They're made in tiny amounts pretty much everywhere in the body, but they act right where they're made. And then they get broken down really, really quickly, so they don't tend to circulate much in the blood. Think of them as very specific local signals, fine-tuning the environment.
And the raw material for all this is arachidonic acid, pulled from the cell membrane.
Exactly right. Step 1 is releasing arachidonic acid from the phospholipids in the cell membrane. That's done by an enzyme called phospholipase A2. Once it's free, this acid goes down one of two main metabolic pathways.
Okay, let's focus on the path that's most relevant for the drugs we're talking about, the cyclooxygenase pathway, COX.
Yes, the COX pathway. This is the one that makes those eicosanoids with the ring structure, so prostaglandins themselves, but also thromboxanes and prostacyclins. And critically, there are two main versions, or isoforms, of this COX enzyme. Understanding the difference between COX-1 and COX-2, well, that's absolutely fundamental to mastering NSAIDs.
Okay, break them down for us. COX-1 first.
All right. COX-1 is what we call the constitutive isoform, meaning it's pretty much always there, expressed in normal cells. It handles the baseline, the physiologic production of these prostanoids. Think of it as the housekeeper. It does essential jobs like protecting the stomach lining, gastric cytoprotection, maintaining blood flow to the kidneys, vascular homeostasis, and importantly, helping platelets stick together.
So it's the good COX, basically, keeping normal functions going.
You could say that, yeah. It's vital for normal function. Then you have COX-2. This is often called the inducible isoform. Its production gets massively ramped up, induced at sites where there's inflammation or chronic disease, and what induces it? Typically those pro-inflammatory cytokines we mentioned, like TNF-alpha and IL-1.
So inhibiting TOX2 is the main goal for fighting inflammation.
That's the primary target for the anti-inflammatory effect, yes.
But I remember the sources mentioning COX2 isn't just inducible, it's also present normally in some tissues.
That's a crucial point and a complication. Yes, it's constitutively expressed, meaning it's there all the time in certain healthy tissues, specifically the brain, the kidney, and also in bone. And this is important because it means that even if you have a drug that only hits COX-2, you can still interfere with normal processes in those tissues. It helps explain some of the side effects like kidney issues or cardiovascular concerns, even with selective inhibitors.
Okay, let's zoom in on the structure, because the difference in structure is how they managed to create selective COX2 inhibitors, right?
Exactly. This is a really neat bit of pharmacology essential for that mastery level. So COX1 has a fairly narrow channel leading to its active site where the arachidonic acid binds. COX2, however, has a larger, more flexible channel. And crucially, it has this extra side pocket, kind of a bulky space near the active site. So the selective COX2 inhibitors, like celecoxib, were designed very cleverly. They have these larger side chains that can fit neatly into the wider channel and that side pocket of COX2.
But they're too big for COX1.
Precisely. They're physically too bulky to get into the narrower channel of COX1. So they block COX2, but they leave COX1 largely untouched. That structural difference is what enables the selectivity.
And just quickly, where do glucocorticoids like prednisone fit in? Do they just bypass this whole COX thing?
Well, partly yes. Glucocorticoids are powerful anti-inflammatories for several reasons, but one key action is that they actually inhibit the induction and the expression of the COX2 enzyme itself. So they reduce the amount of COX2 enzyme available to even make those inflammatory prostaglandins in the first place.
Okay. And the other pathway for arachidonic acid, the lipoxygenase one, briefly.
Right, the lipoxygenase pathway. If arachidonic acid goes down this route, it gets turned into leukotrienes. We mention this mainly because it's hugely important in respiratory diseases. Leukotrienes cause airways to constrict. They're major players in asthma.
Ah, so the asthma drugs.
Exactly. Drugs that either stop leukotriene formation, like Xileuton, or block the receptors like zafirlukast or montelukast. These are cornerstone treatments for asthma. Different pathway, different target, different disease.
Got it. Let's loop back to prostaglandins and that really delicate balance you mentioned earlier, the one affecting blood vessels and platelets. Thromboxane A2 versus prostacyclin.
Yes, TXA2 versus PGI2. This balance is absolutely core to understanding the cardiovascular risks and benefits of NSAIDs. So these prostanoids work by binding to specific receptors, typically G-protein-coupled receptors. Thromboxane A2, or TXA2, is mainly released by platelets. Its job is to make platelets aggregate, stick together, and cause local blood vessels to constrict, essential for forming a clot. Prostacyclin, PGI2, is made by the endothelial cells, the cells lining the blood vessels, and its actions are the complete opposite. It inhibits platelet aggregation, and it's a potent vasodilator. It widens blood vessels.
So clotting versus anti-clotting, constriction versus dilation.
Exactly. The overall effect on your blood vessels, on your tendency to clot, depends entirely on the relative balance between how much TXA2 is around versus how much PGI2 is around at any given moment. It's a constant push and pull.
That perfectly sets up the discussion on NSAID risks later. But first, let's look at how we actually use prostaglandin analogs as drugs. It's amazing how diverse the uses are.
It really is. We've effectively weaponized these natural signaling molecules. Take out Prostadil. It's an analog of PGE1. In newborns with certain heart defects, it's used to keep the ductus arteriosus open. This vessel normally closes after birth, but keeping it open can maintain vital blood flow, buying time for surgery.
And totally different use.
Totally different. It's also injected or inserted to treat erectile dysfunction by causing vasodilation. Same molecule, wildly different applications.
Okay, what about GI uses?
There's lubiprostone. This is a derivative of PGE1. It's used for chronic constipation, particularly idiopathic constipation, or IBS with constipation. How it works is, locally in the gut, it stimulates chloride channels. This pulls water into the intestines, increases fluid secretion, softens the stool.
Side effects.
Pretty predictable, really. Nausea and diarrhea are the main ones you'd counsel patients about.
And then there's misoprostol. This one comes with a huge warning label, doesn't it? Because it works in two different systems.
Yes, absolutely, a critical warning. Misoprostol is another PGE1 analog. Its main approved use is to protect the stomach lining for people taking chronic NSAIDs. It reduces stomach acid and boosts the protective mucus and bicarbonate. However, it also powerfully stimulates uterine contractions. It's used off-label to induce labor. Because of this, it is absolutely 100% contraindicated in pregnancy. It carries a very high risk of causing an abortion or premature birth. Extremely important point.
Right. We also see PGF2A analogs used in eye care.
Correct. Drugs like binaprost, latanoprost, travoprost, these are analogs of PGF2A. They're first-line treatments for open-angle glaucoma. Their mechanism is to increase the outflow of aqueous humor from the eye, specifically through the uveoscleral pathway. This lowers the pressure inside the eye.
And bimatoprost has that interesting cosmetic use, too.
It does. Bimatoprost, under a different brand name, Latisse, is approved for treating hypotrichosis of the eyelashes, basically, helping people grow longer, thicker, darker eyelashes. A side effect turned into a product.
Fascinating. Okay, lastly in this section, the really serious cardiovascular drugs, the prostacyclin analogues for pulmonary hypertension.
Yes, these are for a life-threatening condition, pulmonary arterial hypertension, PAH. Drugs like epoprostenol, iloprost, and treprostinil mimic the action of PGI2. They are potent pulmonary vasodilators. They relax the blood vessels in the lungs, significantly reducing the pressure and resistance there, which takes strain off the right side of the heart and improves the cardiac index.
But they're tricky to use.
Very tricky. Natural PGI2 has an incredibly short half-life. It's broken down in minutes. These synthetic analogs also tend to have short half-lives. This means administration is often complex. Epoprostenol usually requires a continuous IV infusion through a central line. Iloprost is inhaled multiple times a day. Treprostinil can be given subcutaneously or IV. So yeah, these are generally reserved for more severe cases due to the administration burden and side effects like flushing, headache, and jaw pain.
All right, let's shift gears now to the absolute core of this topic for many people, the NSAIDs, Nonsteroidal Anti-inflammatory Drugs. Chemically, they look quite different. You've got salicylates, propionic acids, acetic acids, but they're all grouped together. Why?
Because they share that fundamental mechanism. They are defined by their ability to inhibit the cyclooxygenase enzymes, the COX enzymes. By doing that, they shut down prostaglandin synthesis. That's the unifying feature.
And as you said, the difference between them often comes down to which COX they hit harder.
Exactly. The clinical effects, both the good and the bad, really hinge on their relative selectivity for KOX1 versus KOX2. Remember, inhibiting the inducible KOX2 is what gives you the desired anti-inflammatory and analgesic effects. Inhibiting the constitutive COX1, well, that's what primarily causes the GI side effects and the bleeding risk. But paradoxically, it's also the key to aspirin's cardioprotective effect.
Okay, for that elite mastery, let's quickly run through the major chemical classes. Structure can sometimes predict behavior, right?
It can give clues, yeah. So first you have the salicylic acid derivatives. The most famous, of course, is aspirin, which is unique because it's an irreversible inhibitor. We'll come back to that. Then the propionic acid derivatives, very common class. Includes things like ibuprofen and the longer-acting naproxen. Acetic acid derivatives are another group. Examples here are indomethacin, often a go-to for acute gout, and ketorolac, which is very potent, usually reserved for short-term, moderate to severe pain, often post-op, and has a limit on duration of use due to toxicity. And finally, that specialized class we mentioned, the highly selective KOX2 inhibitor, celecoxib.
Got it. Now, NSAIDs are often known for having three main therapeutic actions. Let's detail those. The triple threat.
Right. Action number one, analgesic or pain relief. How does this work? Well, prostaglandin E2, PGE2, doesn't directly cause pain itself, but it makes nerve endings much more sensitive to other pain mediators, things like bradykinin and histamine. So by inhibiting PGE2 synthesis, and this is thought to be mainly via KOX2 inhibition and active, stop that sensitization, they raise the pain threshold, reduce the signaling.
Okay, pain relief, number two.
Anti-inflammatory action. This is about reducing those prostaglandin-mediated aspects of inflammation, the vasodilation, the swelling, the redness. But, and this is a really critical point to grasp, NSAIDs only modulate the inflammation, they treat the symptoms, they do not stop the underlying disease progression in conditions like RA. That's what DMARDs are for.
And dose matters here.
Big time. For many NSAIDs, especially salicylates like aspirin, the dose needed for significant anti-inflammatory effects is much higher than the dose needed just for pain relief. For aspirin, you might need over 4 grams a day for anti-inflammatory action, whereas a much lower dose works for pain.
Okay, and the third action?
Antipyretic action, or fever reduction. Fever happens when inflammatory signals trigger PGE2 synthesis in the hypothalamus, the brain's thermostat raising its set point. NSAIDs block this PGE2 production in the hypothalamus. This resets the thermostat back towards normal. The body then tries to cool down through vasodilation, flushing, and sweating.
Importantly, they don't lower normal body temperature.
No, absolutely not. Only elevated temperature due to that PGE2 mechanism.
Okay, let's drill down on aspirin now. You said it's unique and irreversible inhibitor. What does that actually mean in practice? Acetylating COX.
It means that when aspirin binds to the cyclooxygenase enzyme, it forms a permanent covalent bond specifically. It acetylates a serine residue in the active site. This permanently inactivates that enzyme molecule. Other NSAIDs bind reversibly. They attach, block, and then detach. Aspirin attaches and kills the enzyme function for good.
And this is huge for cardiovascular protection.
Absolutely huge, especially at low doses, typically 75 to 162 milligrams daily. Here's why. Platelets are basically just cell fragments. They don't have a nucleus. So they can't make new proteins, including new COX-1 enzyme. When low-dose aspirin irreversibly knocks out the COX-1 in a platelet, that platelet cannot make thromboxane A2 for the rest of its life, which is about 3 to 7 days.
So you get a sustained anti-clotting effect.
Exactly, a sustained reduction in platelet aggregation. That's why low-dose aspirin is used prophylactically to reduce the risk of heart attack, MI, stroke, and TIAs. It's targeting COX-1 in the platelet.
But this benefit comes with a really scary risk in kids and teens. Rey syndrome.
Yes, a critical contraindication. Aspirin must be avoided in anyone under 19 years old who has symptoms of a viral infection, especially chickenpox, varicella, or the flu, influenza. Rey syndrome is rare, but it's devastating. It involves acute liver failure and swelling of the brain, cerebral edema. It can be fatal. This is precisely why acetaminophen or ibuprofen are the preferred choices for fever or pain in children with viral illnesses.
I also saw something fascinating in the sources about how aspirin's elimination changes with dose. It shifts kinetics.
Yes, this is a classic mastery point for aspirin. At the low analgesic or antiplatelet doses, aspirin follows normal first-order elimination. Its half-life is relatively short, around 3.5 hours, predictable. But when you push the dose up into the high anti-inflammatory range, we're talking over 4 grams a day, the liver's main metabolic pathway for it, conjugation with glycine, gets saturated. It just can't keep up.
So what happens then?
Elimination switches to zero-order kinetics. This means the body can only clear a fixed amount of aspirin per unit time, regardless of how much is in the blood. The half-life shoots up dramatically to 15 hours or even longer.
That sounds dangerous.
It is, because small increases in dose can lead to disproportionately large jumps in plasma concentration and toxicity. This can lead to salicylism symptoms like ringing in the ears, tinnitus, hearing loss, dizziness, confusion, or even more severe overdose. Clinicians have to be incredibly careful with high-dose aspirin regimens.
Okay, let's tackle the big 4 categories of NSAI side effects, starting with the most common one, the GI problems.
Right, gastrointestinal adverse events. This is almost entirely down to inhibiting COX-1. Remember, COX-1 makes those protective prostaglandins, PGI2, PGE2, PGF2A, in the stomach lining. These prostaglandins normally stimulate mucus and bicarbonate production, and they inhibit acid secretion. When you block COX-1, you lose that protection. You get more acid, less protective mucus,
Leading to
dyspepsia, indigestion, heartburn, abdominal pain, and more seriously, peptic ulcers and potentially life-threatening GI bleeding. The risk is generally higher with NSAIDs that are more selective for COX-1 or used at higher doses or for longer durations.
How do you manage that risk in someone who needs chronic NSAIDs?
For high-risk patients, maybe older folks, people with a history of ulcers, those on anticoagulants co-prescribing a proton pump inhibitor, PPI, like omeprazole, or the prostaglandin analog misoprostol is often standard practice for gastric protection.
Okay, GI risk. Second major area, bleeding risk, beyond just the gut.
Yes, because COX-1 is also crucial for platelet TX-8 production. Inhibiting it affects clotting in general. All NSAIDs can prolong bleeding time to some extent because they inhibit platelet aggregation. Aspirin is the most potent here because its effect is irreversible and lasts for the platelet's lifespan.
And there's that tricky interaction if someone takes aspirin for their heart, but also needs ibuprofen for pain.
Yes, this is a clinically vital interaction. If you take a reversible NSAID like ibuprofen at the same time as, or shortly before, your low-dose aspirin, the ibuprofen can temporarily sit in the COX-1 binding site on the platelet. It physically blocks the aspirin from getting in to do its irreversible acetylation job.
So the aspirin doesn't work properly for heart protection.
Exactly. It negates the long-lasting antiplatelet effect you want from the aspirin. The practical advice: if you need both, take the aspirin at least 30 minutes before taking the ibuprofen or other non-selective NSAID. Let the aspirin bind irreversibly first.
Good tip. Okay, third risk area.
Yeah.
Kidneys, renal effects, especially risky for some patients.
Very much so. This is a classic pitfall. In the kidneys, prostaglandins like PGE2 and PGI2 play a vital role in maintaining blood flow, particularly by causing vasodilation of the areole, the vessel bringing blood into the filtering unit. Now, in healthy people with good kidney function, this might not be a huge issue, but in patients whose kidney perfusion is already compromised, think people with heart failure, cirrhosis, chronic kidney disease, or those who are volume depleted perhaps from diuretics, they become heavily reliant on these prostaglandins to keep the kidneys perfused.
So NSAIDs knock out that support.
Precisely. NSAID use inhibits this protective vasodilation. This leaves vasoconstrictive forces like angiotensin II unopposed. Renal blood flow drops. The kidneys retain sodium and water, leading to edema, potentially worsening heart failure or hypertension. And in severe cases, it can precipitate acute kidney injury or acute renal failure. You have to be extremely cautious using NSAIDs in these patient groups.
Right. And the fourth major risk, the one with the big boxed warning, cardiovascular effects. Increased risk of heart attack and stroke. This applies to almost all NSAIDs.
Yes, all NSAIDs, except for low-dose aspirin, carry a boxed warning about increased risk of serious cardiovascular thrombotic events, including MI and stroke.
Why? What's the mechanism here? Back to that balance.
Exactly, back to the TXA2-PGI2 balance. The thinking is that most NSAIDs, especially those that are more selective for TOX2, tend to inhibit the production of PGI2, the beneficial vasodilator and anti-aggregator made by endothelial cells, more effectively than they inhibit TXA2, the pro-aggregator made by platelets. By knocking down PGI2 while leaving TXA2 activity relatively unopposed, you shift that delicate balance towards a prothrombotic state favoring platelet aggregation and vasoconstriction. This is believed to underpin the increased risk of heart attack and stroke.
Well, the sources mentioned naproxen might be a bit safer from a CV perspective. Why would that be?
That's a nuanced point, often debated, but there is some evidence suggesting naproxen might carry a lower CV risk compared to some other non-selective NSAIDs or selective KOX2 inhibitors. The rationale often proposed relates to its pharmacokinetics. Naproxen has a relatively long half-life compared to, say, ibuprofen. This means it provides more sustained inhibition of KOX1 throughout the dosing interval. While it inhibits both KOX1 and KOX2, the sustained suppression of platelet COX1 and thus TXA2 might better counterbalance the inhibition of KOX2 and PGI2, potentially leading to a less prothrombotic overall effect compared to shorter-acting agents where TXA2 activity might rebound more significantly between doses. It's complex, but naproxen is often considered a preferred choice if an NSAID is absolutely necessary in a patient with existing cardiovascular disease.
Interesting. Okay, let's talk about celecoxib, the selective COX2 inhibitor. It was designed specifically to avoid the GI problems of KOX1 inhibition.
That was the hope, yes. Celecoxib is a reversible inhibitor that is highly selective for the TOX2 enzyme, and it does generally cause less GI bleeding and dyspepsia compared to non-selective NSAIDs like ibuprofen or naproxen, at least when used alone.
Oh.
But two big caveats. First, that GI benefit is largely lost if the patient also needs to take low-dose aspirin for cardiovascular protection. The aspirin itself carries GI risk. Second, and crucially, because it selectively inhibits COX2, and thus PGI2, without significantly affecting platelet COX1 and TXA2, it still carries that same boxed warning for increased cardiovascular risk. It might be easier on the stomach, but not necessarily safer for the heart.
So a trade-off. Okay, our final drug in this section, acetaminophen, or paracetamol in some places. Definitely not an NSAID, right?
Correct. Very important distinction. Acetaminophen is in a class of its own. It does inhibit prostaglandin synthesis, but the key difference is where it works. It seems to act primarily in the central nervous system, CNS. This CNS action explains why it's effective as an analgesic for pain and an antipyretic for fever. But outside the CNS, in peripheral tissues where inflammation is happening, it gets inactivated by high levels of peroxides present there.
Meaning weak anti-inflammatory effect.
Very weak peripheral anti-inflammatory activity, which is actually an advantage in many situations. If you don't need anti-inflammatory action, APAP avoids all the COX-1-related side effects of NSAIDs. That makes it the drug of choice for pain or fever in patients at high risk for GI bleeding, those on anticoagulants, people with kidney issues where NSAIDs are risky, certainly for children with viral illnesses to avoid rise, and is generally considered safer during pregnancy than NSAIDs.
So lots of advantages, but then there's the dark side. The liver toxicity is uniquely dangerous in overdose.
Uniquely and terrifyingly so, yes. This is critical knowledge because APAP is in so many products, and overdose, often accidental, is common. Here's the mechanism. A small fraction of acetaminophen is normally metabolized by the liver's cytochrome P450 system into a highly reactive, toxic intermediate metabolite called NAPQI. Normally, NAPQI is immediately detoxified. The liver uses its stores of glutathione to conjugate NAPQI, rendering it harmless, and it gets excreted.
But in an overdose.
In an overdose, you overwhelm that pathway. The liver's stores of glutathione get completely used up, depleted. When there's no glutathione left, the toxic NAPQI starts reacting with critical proteins and molecules within the liver cells, particularly binding to sulfhydryl groups. This causes widespread cellular damage, oxidative stress, and ultimately potentially fatal liver necrosis or liver failure.
And the antidote works by restoring glutathione.
Exactly. The antidote is N-acetylcysteine, or NAC. It works primarily by replenishing the liver's glutathione stores, allowing the detoxification of NAPQI to resume. It can also act as a glutathione substitute itself, but it has to be given quickly after the overdose before too much irreversible liver damage occurs. Timing is absolutely critical.
Okay, we've covered drugs that manage symptoms like pain and inflammation. But as you said, NSAIDs don't stop the underlying disease in conditions like rheumatoid arthritis. For that, we need a different class of drugs entirely. Let's move into the disease-modifying antirheumatic drugs, the DMARDs. These aren't just the symptoms. They aim to change the course of the disease, right? Often started right away.
Yes, that's the modern approach. For RA, DMARDs are typically initiated as soon as the diagnosis is confirmed. The goal is to interfere with the underlying autoimmune pathology, slow down or halt the joint destruction, prevent long-term disability, and hopefully induce remission. We're moving from symptom control to disease modification.
So how do they do that? What's the target in IRA again?
We're going after that whole inflammatory cascade driven by the immune system attacking the synovium. We need to interrupt the communication network, stop the activation of T lymphocytes, block the signals they send out, like TNF-alpha and IL-1, and reduce the production of autoantibodies by B lymphocytes.
Let's start with the traditional or conventional synthetic DMARDs. And the absolute cornerstone here seems to be methotrexate, MTX.
Methotrexate is the anchor drug, absolutely. It's usually the first DMARD tried for moderate to severe RA. Chemically, it's a folic acid antagonist. Now, importantly, the doses used for RA are much lower than those used in cancer chemotherapy, and it's typically given just once a week. At these low doses, its main effects in RA are thought to be inhibiting cytokine production and interfering with purine nucleotide biosynthesis.
Stopping immune cells from multiplying.
Essentially, yes. It dampens down the proliferation and activity of those overactive immune cells driving the inflammation. MTX is highly effective, often shows results within 3 to 6 weeks, and it's really the standard against which other RA therapies are compared.
But it has a reputation for significant toxicity. Why is that, and how is it managed?
Because it messes with folic acid metabolism, it can affect any rapidly dividing cells, not just immune cells. This includes cells lining the mouth and gut, hair follicles, and bone marrow cells. So common side effects include mouth sores, stomatitis, nausea, diarrhea, hair thinning. More seriously, it can cause bone marrow suppression, leading to low blood count cytopenias, and long-term use carries a risk of liver damage, fibrosis or cirrhosis, and lung problems, pneumonitis.
So how do you make it tolerable?
The key management strategy is folic acid supplementation. Patients on MTX are almost always prescribed folic acid supplements, usually taken on the days they don't take their MTX. This provides enough folate for normal cells to function, significantly reducing many of the side effects, especially the mucosal and hematologic ones, without seemingly compromising the anti-rheumatic effectiveness of the MTX itself. It's a partial rescue.
And like misoprostol, a huge warning about pregnancy.
Absolutely non-negotiable. Methotrexate is a potent teratogen. It is strictly contraindicated in pregnancy and requires effective contraception in women of childbearing potential.
Okay. What about leflunomide, another traditional DMARD, also with a pregnancy warning, different mechanism?
Yes, leflunomide works differently. It's also an immunomodulatory agent, but it targets pyrimidine synthesis, whereas MTX targets purines and folate pathways. Leflunomide gets converted in the body to an active metabolite, which reversibly inhibits an enzyme called dihydrorotate dehydrogenase, or DHODH. DHODH is essential for making pyrimidines, which are building blocks for DNA and RNA. By blocking it, leflunomide halts the proliferation of rapidly dividing lymphocytes, particularly T cells, putting them into cell cycle arrest.
Similar side effects to MTX.
It shares some, like potential liver toxicity requiring monitoring, and hair loss. Diarrhea can also be prominent. And yes, like MTX, it is absolutely contraindicated in pregnancy due to teratogenicity. It also has a very long half-life, meaning it sticks around in the body for a long time, which needs consideration if pregnancy is planned.
Are there other traditional options for maybe milder RA?
Yes, a couple more sometimes used, often in combination or for less severe disease. Hydroxychloroquine, which you might know as Plaquenil, is one. It's generally considered less toxic systemically than MPX or leflunomide. It's often used for early mild RA or in combination therapy. The main concern with hydroxychloroquine is the potential for irreversible retinal damage, ocular toxicity. So, regular eye exams are essential for patients on long-term therapy.
And sulfasalazine.
Sulfasalazine is another one. Its exact mechanism in RA isn't perfectly clear, but it has anti-inflammatory and immunomodulatory effects. It's broken down in the gut into sulfapyridine and 5-aminosalicylic acid. Common side effects are GI upset, nausea, vomiting, headache, and rash. It can also cause leukopenia, low white blood cell count, so blood monitoring is needed. It's often used in combination therapy.
And where do steroids, the glucocorticoids, fit in with these DMARDs?
Glucocorticoids like prednisone play a crucial role, particularly as bridge therapy. DMARDs, whether traditional or biologic, take time to work weeks or sometimes months to reach their full effect. Steroids, on the other hand, provide powerful, rapid anti-inflammatory and immunosuppressive effects. So they're often started alongside a DMARD to give the patient quick symptom relief while waiting for the slower-acting DMARD to kick in.
But you want to get off them quickly.
Absolutely. The goal is always the lowest effective dose for the shortest possible duration, tapering off as the DMARD takes effect. This is to minimize the multitude of serious long-term side effects associated with chronic steroid use: weight gain, osteoporosis, diabetes, infections, mood changes, skin thinning, and so on.
Okay, so that's the traditional DMARDs. What happens when those aren't enough or the RA is very aggressive? We move to the biologics.
Correct. The biologic DMARDs represent a major advance. These are generally proteins, often monoclonal antibodies or fusion proteins engineered to target specific molecules involved in the inflammatory and immune process, like cytokines or immune cells.
But they come with a big, overarching safety warning.
A huge one. This is critical for anyone managing these drugs. Because biologic DMARDs work by deliberately suppressing specific parts of the immune system, they significantly increase the patient's risk of developing serious infections. This includes bacterial infections like sepsis, opportunistic fungal infections, reactivation of latent tuberculosis, TB, and reactivation of hepatitis B virus, HBV.
So screening is vital beforehand.
Essential. Patients must be screened for latent TB and HBV before starting most biologic DMARDs. And importantly, patients on these drugs should not receive live vaccines, as they could potentially cause infection in an immunosuppressed person. And another absolute rule: you should never use two different biologic DMARDs together, particularly not a TNF inhibitor with a non-TNF biologic. The risk of serious infection becomes unacceptably high.
Okay, let's talk about the biggest class of biologics, the TNF-alpha inhibitors.
Right. TNF-alpha, as we said, is a master pro-inflammatory cytokine, really central to the RA process, so blocking it makes a lot of sense. There are several TNF inhibitors available: adalimumab, Humira, etanercept and Brel, infliximab, Remicade, golimumab, Simponi, certolizumab pegol, Cimzia. They work slightly differently. Some are full antibodies. Etanercept is a fusion protein acting like a decoy receptor, but they all block TNF-alpha activity.
And they work well.
Generally very well, and often quite rapidly. Patients can feel improvement within a couple of weeks sometimes. They're usually given by subcutaneous injection, most, or IV infusion, infliximab.
What are the specific warnings for TNF inhibitors beyond the general infection risk?
A few key ones. They can potentially cause or worsen pre-existing heart failure, so they're used cautiously or avoided in patients with significant heart failure. There's also an observed increased risk of certain malignancies, including lymphoma and skin cancers, although the absolute risk is still relatively low. Demyelinating disorders, like multiple sclerosis, have rarely been reported, and infusion or injection site reactions can occur.
You mentioned infliximab is different, chimeric.
Yes, infliximab is a chimeric monoclonal antibody, meaning it's partly mouse protein and partly human protein. Because of the mouse component, the patient's immune system can develop antibodies against the drug itself, anti-drug antibodies. These antibodies can lead to infusion reactions and, more importantly, reduce the drug's effectiveness over time. To minimize this risk, infliximab must always be given in combination with methotrexate. The MTX helps suppress the immune response against the infliximab.
Clever. Okay, what about biologics that don't target TNF? The non-TNF biologics. Let's start with the T-cell blocker, abatacept.
Abatacept Orencia has a really elegant mechanism. It targets T-cell activation. Remember, for a T-cell to get fully activated, it needs two signals. Signal 1 is seeing the antigen. Signal 2 is a stimulatory signal, usually when CD28 on the T-cell binds to CD80 or CD86 on the antigen-presenting cell. Abatacept is a fusion protein that looks like CTLA4, which naturally binds to CD86. So abatacept essentially gets in the way. It binds to CD86 and prevents them from engaging with CD28 on the T cell.
Blocking signal 2.
Exactly. By blocking that crucial second signal, it prevents full T-cell activation, thereby dampening down the whole downstream immune cascade. It's usually given by IV infusion or subcutaneous injection.
And then there's rituximab, which goes after B cells.
Right. Rituximab, Rituxan, is a chimeric monoclonal antibody that targets the CD20 protein, which is found on the surface of B lymphocytes, but not on plasma cells, the ones actually making antibodies long-term. Binding of rituximab leads to the depletion of these CD20 positive B cells from the circulation. Why does this help in RA? Because B cells play multiple roles. They present antigens to T cells, they produce autoantibodies like rheumatoid factor, and they secrete cytokines.
So taking them out hits the disease from several angles.
Precisely. Rituximab is typically given as 2 IV infusions 2 weeks apart, and the course might be repeated every 6 months or so. Because it's chimeric and targets cells directly, infusion reactions can be quite common and sometimes severe. Therefore, patients are always premedicated before each infusion with a corticosteroid, acetaminophen, and antihistamine to reduce the risk and severity of these reactions.
Okay, we also have drugs targeting another cytokine, IL-6.
Yes, interleukin-6, IL-6, is another important pro-inflammatory cytokine in RA. We have IL-6 receptor blockers like tocilizumab, Actemra, and seralutinib, Kevzara. These are monoclonal antibodies that bind to the IL-6 receptor, preventing IL-6 from signaling. They are effective options given by IV infusion or subcutaneous injection. Specific risks to monitor with these include potential elevations in liver function tests, LFTs, changes in blood lipid levels, hyperlipidemia, and decreases in neutrophil counts, neutropenia, in addition to the general infection risk.
Right, that covers the main biologics.
Sure.
There's one more class for RA, the oral JK inhibitors. Tofacitinib.
Yes, this is a newer class of oral synthetic DMARDs, not biologics. Tofacitinib, Soljans, is the first-in-class Janus kinase, or JK inhibitor. JKs are enzymes inside immune cells. They are crucial for transducing the signals that come from cytokine receptors on the cell surface down to the nucleus, telling the cell what to do. By inhibiting JKs, tofacitinib primarily hits JAK1 and JAK3, you block the signaling pathways for multiple cytokines simultaneously.
So it's a broader intracellular approach.
It is. And being oral is a big advantage for patients. However, because it has broader effects and due to some long-term safety signals observed in studies, particularly regarding serious infections, malignancy, including lymphoma, and blood clots, thrombosis, tofacitinib, and other JAK inhibitors, are generally reserved for patients with moderate to severe RA who haven't responded adequately to or can't tolerate methotrexate or potentially biologics.
Requires careful monitoring, too.
Yes, regular monitoring of blood counts, hemoglobin, lymphocytes, neutrophils, and lipids is necessary, alongside vigilance for infection and malignancy.
Okay, let's make our final shift. We're moving away from autoimmune inflammation like RA and into gout. This is different, isn't it? It's fundamentally a metabolic problem.
That's right. Gout isn't primarily autoimmune. It's caused by hyperuricemia, having too much uric acid in the blood. Uric acid is a normal breakdown product of purines from diet and cell turnover. When levels get too high, uric acid can crystallize out of the blood, forming monosodium urate MSU crystals. These needle-sharp crystals tend to deposit in joints, especially the big toe, but also in soft tissues and the kidneys.
And the painful gout attack, the flare. That's the crystals themselves causing pain.
Not directly. The intense inflammation of an acute gouty flare happens when the body's innate immune system, particularly neutrophils, recognizes these crystals as foreign invaders. Neutrophils flock to the joint and try to engulf, phagocytize the crystals. In the process, they release a whole host of inflammatory mediators, cytokines, chemokines, lysosomal enzymes. This triggers an intense inflammatory response. Severe pain, swelling, redness, heat in the joint. It's excruciating.
So the treatment goals are?
Twofold. First, treat the acute inflammation and pain of the flare when it happens. Second, for people with recurrent flares or established gout, the long-term goal is to lower the serum uric acid level below its saturation point, typically aiming for less than 6 mg/dL to prevent further crystal formation and gradually dissolve existing crystals. This is called urate-lowering therapy, or ULT.
Okay, let's start with managing the acute attack. What works best?
For an acute flare, the mainstays are NSAIDs used at high anti-inflammatory doses, corticosteroids, either given systemically, like oral prednisone, or injected directly into the affected joint, intra-articular injection, and colchicine.
You mentioned indomethacin as a classic NSAID choice for gout.
Yes, indomethacin has historically been widely used and studied for acute gout, often considered a reference NSAID, but other NSAIDs like naproxen or ibuprofen at appropriate doses are also effective. The key is starting treatment early in the flare.
What about colchicine? You said it was unique, not really an analgesic.
Correct. Colchicine is fascinating. It's an old drug derived from the autumn crocus plant. It's specifically anti-inflammatory for gout, but it doesn't provide general pain relief like NSAIDs, nor does it affect uric acid levels. It's not uricosuric. Its mechanism is unique. Colchicine binds to tubulin, a protein that makes up microtubules within cells. Microtubules are essential for cell structure and movement. By disrupting microtubule assembly, colchicine specifically inhibits the motility and migration of neutrophils.
So it stops the inflammatory cells from getting to the joint.
Pretty much, yeah. It prevents them from chemotaxing towards the crystals and amplifying the inflammation. For it to work best in an acute flare, it really needs to be started very early, ideally within the first 12 to 36 hours of symptom onset. Colchicine is also often used in low doses prophylactically, especially when starting ULT, to prevent the flares that can sometimes be triggered as uric acid levels start to change.
Right. Now, let's talk about chronic management, the urate-lowering therapy, ULT. How do we lower uric acid long-term?
There are two main strategies. Either reduce the production of uric acid or increase its excretion by the kidneys.
Okay, reducing production first.
The first-line agents for ULT are the xanthine oxidase, XO inhibitors. Xanthine oxidase is the key enzyme that catalyzes the final two steps in the metabolic pathway that produces uric acid from purines. The classic XO inhibitor is allopurinol. It's a purine analog itself, and it works by competitively inhibiting xanthine oxidase. Interestingly, its main metabolite, oxypurinol, or aloctantine, is also an active inhibitor and has a very long half-life, around 15 to 18 hours. This allows allopurinol to be dosed just once daily.
Side effects of allopurinol.
The most common are things like rash and GI upset. However, the most feared complication is allopurinol hypersensitivity syndrome, AHS. It's rare but potentially life-threatening, involving severe rash like Stevens-Johnson syndrome, fever, organ damage, liver, kidneys. There's a genetic link, particularly with the HLA-B5801 allele, which is more common in certain Asian populations, leading some guidelines to recommend screening for this allele before starting allopurinol in those groups.
And you mentioned a critical drug interaction earlier involving allopurinol.
Yes, absolutely vital to know. Allopurinol significantly inhibits the metabolism of the purine antimetabolites azathioprine and 6-mercaptopurine, 6-MP. These drugs are used as immunosuppressants, for example, in IBD, transplantation, or in cancer chemotherapy. If you give allopurinol to someone taking azathioprine or 6-MP without drastically reducing the dose of those drugs, often by 60–75%, you will get potentially fatal toxicity, mainly severe bone marrow suppression. It's a critical interaction requiring dose adjustment and careful monitoring.
Okay, what's the alternative XO inhibitor? Febuxostat.
Yes, febuxostat, Uloric, is another XO inhibitor. Structurally, it's completely different from allopurinol. It's non-purine. It's generally more potent than allopurinol on a mg/mg basis and requires less dose adjustment in patients with kidney disease. However, there have been concerns raised about its cardiovascular safety. Some studies suggested a potentially higher risk of cardiovascular death with febuxostat compared to allopurinol, leading to a boxed warning in the U.S., although the interpretation of this data is complex. It's often considered a second-line option after allopurinol, or for patients who can't tolerate allopurinol.
So that's reducing production. What about increasing excretion? The uricosuric drugs.
Right. If XO inhibitors aren't enough or aren't tolerated, the next step might be to add or switch to a uricosuric agent, which works by increasing the amount of uric acid the kidneys excrete in the urine. The main oral uricosuric drug is probenecid. It works in the proximal tubule of the kidney. It primarily blocks a transporter called URAT1, urate transporter 1, which is responsible for reabsorbing uric acid back into the bloodstream from the urine filtrate. By blocking reabsorption, more uric acid stays in the urine and gets flushed out.
Any limitations with probenecid?
Yes, a few key ones. It shouldn't be started during an acute gout flare, as shifting uric acid levels can sometimes worsen or prolong the flare. It requires good kidney function to be effective, so it's generally avoided if the patient's creatinine clearance is less than 50 milliliter. Also, because it increases uric acid in the urine, there's a risk of forming uric acid kidney stones, so maintaining good hydration is important. And it can interact with other drugs that are eliminated via the same transporters in the kidney, like penicillin.
Okay. And for the really tough cases, refractory gout, there's one more option.
Yes, for the small percentage of patients with severe, debilitating gout who have failed or cannot tolerate standard oral ULTs, there is a biologic option. Pegloticase, Krystexxa. Pegloticase is a recombinant form of the enzyme uricase, or urate oxidase. Humans naturally lack this enzyme, but it's present in many other mammals. Uricase converts uric acid into a different compound called allantoin, which is much more water-soluble and easily excreted by the kidneys.
So it directly breaks down the uric acid.
Exactly. It provides a very potent and rapid lowering of serum uric acid levels. However, it's reserved for severe refractory cases because it's expensive, requires IV infusions every 2 weeks, and carries a significant risk of infusion reactions and anaphylaxis. Patients often develop antibodies to the drug, which can lead to loss of efficacy and increased reaction risk. Pre-medication is standard before each infusion. #tag outro.
Wow. Okay, looking back over this deep dive, the sheer breadth of knowledge needed here is just incredible. We've gone from blocking one enzyme, COX, for everyday pain, all the way through this targeted molecular warfare against T cells, B cells, cytokines like TNF and IL-6 to try and halt chronic autoimmune destruction in our eye. And finally, ending up managing crystal deposits by interfering with fundamental metabolic pathways in gout. It's quite the spectrum.
It really is. And I think the key takeaway for achieving that elite professional level mastery is truly understanding the nuance, the precise molecular balances, the razor's edge between benefit and risk. Think about that difference. An NSAID potentially increasing heart attack risk by inhibiting the beneficial PGI2, while low-dose aspirin prevents heart attacks by irreversibly inhibiting platelet TXA2. It's the same general target class, COX enzymes, but the specific selectivity, the kinetics, the irreversibility, those details are absolutely critical. We saw how tiny structural differences in the COX1 versus COX2 binding sites allowed for the development of selective drugs. We saw how aspirin's metabolism completely changes from first order to zero order at high doses, drastically altering its risk profile.
And what really stands out, especially with the chronic diseases like RA, is just how potent and frankly toxic some of the necessary treatments are. Drugs like methotrexate, leflunomide, they're highly effective, mainstays of treatment, but they come with risks like liver cirrhosis, severe birth defects. You need careful monitoring, rescue strategies like folic acid, even the incredibly targeted biologics as precise as abatacept blocking that one T cell signal or rituximab wiping out B cells. They still carry this massive risk of serious infection, require complex screening and administration.
It absolutely underscores the reality that we are intervening in fundamental biological processes here. The effectiveness often seems directly tied to the potential for serious side effects, because we're hitting pathways essential for immune function or cell replication, whether it's folic acid metabolism, purine or pyrimidine synthesis, T-cell co-stimulation, or major cytokine signaling.
So as you, the listener, integrate all this deep knowledge, maybe the final provocative thought to consider is this. When the body itself is the aggressor, launching these destructive attacks in autoimmune diseases or failing basic metabolic cleanup in gout. And when our most effective tools to fight back often involve deliberately suppressing the immune system or interfering with core biochemistry, carrying inherent risks of infection or cancer or other severe toxicities, how much systemic vulnerability, how much medically induced risk are we ethically required to accept in order to successfully stop the body from destroying itself? That's the profound high-stakes calculation we face every day when managing these chronic conditions.